allow me to share the screen. I'll have to share the presentation.
Sir, you can share it from your end. There's an option share screen because I don't have any.
Just a minute. Yeah, I'll do that.
Yes, sir.
Don't worry. I'll do that.
Sir.
Thank you. Can you see my screen now?
Yes, sir.
Thank you. So, good evening, everyone. I think this is the concluding session. We have had a lot of brainstorming on Phyllodes diagnosis. And to end it all, pathologists and radiologists both also face this challenge of diagnosing phyllodes tumor correctly. So I would discuss the dilemma in phyllodes diagnosis. To start with, I will be covering this session in these headings which have been listed here. A bit of introduction of phyllodes, the grading of phyllodes, the biological behavior and metastatic potential, the relationship between fibroadenoma and phyllodes tumor. That is more of a similarity than the difference. Then we'll distinguish the cellular fibroadenoma. Adenomas from benign phyllodes. We will distinguish malignant phyllodes from sarcomas, breast sarcomas, and metaplastic breast carcinomas. We will also distinguish pure sarcomas versus phyllodes, fibromatosis, myofibroblastomas, radial scars, PASH, and finally some practical recommendations for patients suffering from phyllodes, how to approach and what is the concluding statement. So, as an introduction, as we know, we have come through a long way in this discussion, but I'll just touch it up quickly. We know that it's a complex group of part of a complex group of mammary fibroepithelial lesions. So it has large ducts with epithelial cells, and these there is a stroma which is classical a leaf-like pattern. The challenges which we face under the microscopes are many in phyllodes. To start with, the grading. It has 3 grades with multiple parameters and all with subjective interpretation. So I'll touch upon some quick points to how to evade these subjective interpretations and how to be precise. Of course, there are again the AMOS challenges which we have discussed earlier in the previous discussions, which comprises of atypia, mitosis, overgrowth, and surgical margins, which are all challenging at the moment. Again, it has a subjective conclusions in all of them, which we would like to avoid in the following discussion. There is no reliable IHC or molecular markers of clinical behavior or statistical importance. That is to be known. And in cytology, it becomes a greater difficulty to distinguish phyllodes from all these entities, which we'll be discussing further on. So after a lot of brainstorming and different grading patterns which have come in, we have finally settled to 2012 World WHO classification, which comprises of benign, borderline, malignant. We will quickly touch it. These are pathological classifications. So we classify them according to stromal cellularity, stromal atypia, mitosis, stromal overgrowth, and tumor margin. I'll just quickly touch each and every points. So the benign ones, they have mild stromal cellularity. If you go towards the malignant, they have the marked stromal cellularity. Stromal atypia is also mild to marked from benign to malignant. And the mitosis, which is very important, is less than 5 in benign and more than 10 in malignant. Anything which falls in between becomes a borderline category. We will discuss about stromal overgrowth, what exactly it is, and how do we see it. So this is what the classification is about in WHO. So let's discuss what is the stromal cellularity. So, and stromal cellularity is basically the cellularity of spindle cells inside the tumor. And how do we assess what is mild, moderate, and marked? So, what I believe and what I do is we focus on the most hypercellular areas. In mild hypercellularity, we see whether they are evenly spaced nuclei that are not notching or overlapping. If you come down to moderate hypercellularity, there is some bit of overlapping of nuclei. In marked hypercellularity, they are confluent areas of densely overlapping nuclei. So this will help us to get away with the subjectiveness. So this is a very important point, which again we will go further down. We'll see how we differentiate from cellular fibrinomas. Stromal atypia is an important point. So how do we classify mild, moderate, and marked? We see that mild nuclear atypia, there is a minimal variation in nuclear size with even chromatin and smooth nuclear contours of these spindle cells. In moderate, there is a more variation in nuclear size and some irregular nuclear membranes. In marked, you have a marked nuclear pleomorphism, hyperchromasia, irregular nuclear contours, and of course, prominence of nucleus. Stromal overgrowth. What is a stromal overgrowth? This came up with the phylloid tumor per se. Stromal overgrowth is defined as the presence of stroma without epithelium. When you see under a low power microscope, you will see sheets of these spindle cells without any intervening epithelial glands or clusters. So a point about biological behavior and metastatic potential. As we know, phylloid tumor, they have been reported from age group 6 to 86 years. There have been phylloid tumor in adolescents, some malignant also in adolescents that have been reported in the literature. But the median age is in 40s, around 40 to 45 years. There is a pattern that they have found in germline P53 mutation, that is Lee-Fraumeni syndrome. They have seen increased risk of malignant PT. As I come towards the journal article, which I will present later on, there is a mother and a daughter who suffered from the breast phylloid tumor with malignant change, and they found out that it was a germline P53 mutation was very prominent in them. See, the overall recurrence rates in the literature are 10 to 17% for benign, 40 to 25% for borderline, and 20 to 30% for malignant phylloids, as per various articles. And Karim et al. Has concluded that Asian patients experience a higher recurrence rate than those of non-Asian ethnicity, but the cause is yet not known. The grade of progression during local recurrence of phylloid tumors can occur. Many reasons have been taken up. So it could be a faulty sampling in the primary breast lesion when it was diagnosed. They missed the area of a borderline or a high-grade sarcoma somewhere. Or there is a stroma heterogeneity, or there are subclones which are lying in the stroma, which can lead to the progression into higher grades. Metastasis and death from phylloid tumors were consistently preceded by a primary malignant diagnosis. So the aim of diagnosing a phylloid tumor has to be to catch the primary malignant variant or primary malignant grade as early as possible and to eradicate or treat it properly. The metastasis usually happens in lung and skeleton, but it can be any organ which can be involved with phylloid tumor. The histologically, metastasis comprises of malignant stromal elements without any epithelium. There have been cases where they have found epithelial elements with stromal elements, but on subsequent immunohistochemistries, they have been found to be a local cellular content rather than the malignant counterpart from the phylloid tumor. Paraneoplastic syndrome has been associated with phylloid tumor. There are cases of insulin-like growth factor 2 and HCG secretion. Some of these patients ended up with hypoglycemic comas also. So this has to be kept in mind. So their metastatic rates have been followed up in multiple journal articles. Very interesting is the journal article from Chen et al. And Abdullah et al., where they found 1.7% and 3.2% benign tumors with metastasis. So overall, the metastatic rate for a malignant phylloid tumor comes to around 16.7% as per various studies. The relationship between fibroadenoma and phylloid tumor is very close, and they look more similar than different, as the study conducted by Zhang et al. So what he concluded was, if you look into the biology of phylloids or the cellular fibroadenomas, he found that the age difference is almost in phylloid tumor is around 35 years, and the age occurrence, mean age occurrence for fibroadenomas is around 27 years. So there is no statistical difference in both of them. The size comparisons is also similar. The low-grade phylloid tumor or the benign phylloid tumor, the age, the size of the lump is around 3 centimeters, and the fibroadenoma is around 2.7 centimeters. There is a whole journal article regarding his study. If you look into the immunohistochemistry, there is no statistical difference between all these. If you compare fibroadenomas with the benign phylloid tumor, they found a lot of overlapping between Ki67, but individually it was a little bit more in low-grade phylloids. It was about 7.7%. You look into P53, there is again an overlapping, but there is a considerable difference between the high-grade phylloids versus the fibroadenoma or low-grade phylloids. As you look into the beta-catenin, almost similar results in fibroadenomas and low-grade phylloids, but the high-grade phylloids has less expression of beta-catenin, the nuclear expression of beta-catenin. The E-catenin was consistently negative in all these cases. They have been studied, but together, if you see the p-value, there is hardly any statistical difference between a low-grade phylloid tumor versus fibroadenoma. There have been studies where they have evaluated the relationship between fibroadenomas and phylloid tumor. The interesting ones I have highlighted in 2012, I told you the mother and daughter pair raised the possibility of genetic predisposition where they had a P53 mutation. And in Lim et al. In 2014, discovered for the first time there is a mutation of MET12 gene, which is present in 59% of fibroadenomas, which again was concluded and reciprocated by Nagaswa and NG et al. That 67% of fibroadenomas and 45% of phylloid tumor do have these mutations. But the interesting fact, which was brought out by NG et al. In 2015, was that tumors with MET12 mutations were associated with a longer disease-free survival, whereas absence of MET12 mutations, it was with a higher likelihood of reoccurrence. This is a very important point. Now we come to the cytology in diagnosis of these cellular fibroepithelial tumors. So you have to differentiate between a cellular fibroadenoma and a benign phylloid. Again, it is a challenge for the pathologist who reports every day. We know that both of them constitute the epithelial element islands and the stromal fragments, plus the bare nuclei at the back. So how do we distinguish? So, Santosh Timidi et al. Studied a lot of these cases and followed up with the biopsy subsequently. He concluded that the stromal features, such as these frayed, irregular borders with increased stromal cellularity, with predominance of spindle cells in all of them, and large open-ended or open-out folded epithelial sheets like these will support more in the diagnosis of phylloid tumor. Subsequently, there's another journal article, Savitri Krishnamurthy. She said that these stromal fragments, if they are studied, if you conclude that it is a 1 plus, 2 plus, or 3 plus cellularity in the stromal fragment, this is a stromal fragment showing a 1 plus cellularity, and this is a stromal fragment showing almost 2 to 3 plus cellularity. If you see that the bare nuclei or the cells at the back are round or oval or a spindle, we can differentiate whether it will come out as a fibroadenoma, a cellular fibroadenoma, or a phylloid tumor. So she concluded by an algorithm which says that if these stromal fragments are 2 plus or 3 plus cellularity, and these spindle cells are about more than 30% of the population of these bare nuclei, there are more chances of it turning out to be a phylloid tumor than a fibroadenoma, which she concluded was almost less than 10%. But a hypercellular fragment of 1 plus, there are about 90% to 100% chance that it will turn out to be a fibroadenoma. These are two interesting studies which have been done on the cytology just to ease out the pathologist's problems under the microscope. Now, since the FNAC techniques for the diagnosis of phylloid tumors are going away in most of the institutions, the tertiary institutions, people are reverting to true-cut biopsies. There are challenges again in true-cut biopsies. So there is an issue regarding diagnosing cellular fibroademas or differentiating them from phylloid tumor, benign phylloid tumor. They are all grouped or most of the time reported as benign fibroepithelial neoplasms or fibroepithelial lesions with cellular stroma. But to help us all, Aziza Nasser et al. Did a study and he found that if you found a prominent mitotic activity that is more than 3 per 10 hyperfield, by itself is adequate to favor a phylloid tumor over cellular fibroadenoma. That was a great help, the study. But what happens if you don't get enough mitosis? You can rely on these different parameters, but at least 3 of these histological features should be there to diagnose that it could favor a phylloid tumor. These are stromal overgrowth, as we can see from here. These are stromal overgrowth, increased stromal cellularity, stromal fragmentation. Now, what is stromal fragmentation? He defines stromal fragmentation are bits of these stroma which are completely lined by these epithelial islands. So this is one of the parameters. Then you can have increased stromal cellularity, stromal fragmentation, infiltration into fat is also a very prominent point to categorize these tumors. Stromal heterogeneity, if you see this part and this part, there is hypercellular and hypercellular areas. This also favors phylloid tumor. Subepithelial condensation of these spindle cells are a very important point, and stromal nuclear pleomorphism. So if you see all these points, you have at least 3 of them. If you can't find enough mitotic activity to classify, you can relatively predict that it will favor a phylloid tumor by at least 3 of them being there. Now, since artificial intelligence and machine learning, deep learning has come a long way, and we are getting regular oncology being done by artificial intelligence, prediction of scores. There is an article which has, or there is a study which has been done by Cheng et al. And he found that there is a 90% chance of having a phylloid tumor, which was reported by a machine learning and a deep learning by the algorithm which was trained, and he could diagnose a fibroadenoma with an accuracy of 80%. Overall, 87.5% he can come to a conclusion that this is a cellular fibroadenoma or a phylloid tumor. That is a huge achievement if you look into the subjectiveness, which is found under the microscope. So this is a very promising results we got. Now, how about resection samples? So resection samples are we are much ease in diagnosing a phylloid tumor over cellular fibroadenomas. We have multiple points. I basically stress on look into the cellular stromas. The hypercellular area stroma is very prominent in low-grade phylloid tumor. They have a prominent leaf-like architecture. These leaves are non-overlapping, jutting inside the duct, which are cystic. So a prominent leaf-like pattern with hypercellular stroma, and you can have stromal overgrowth depending upon the grade. And very important, if you find hypercellular stroma, prominent leaf-like architecture, you should look into the stromal condensation around the ducts. This is where the diagnosis lies, and all these are lacking in fibroadenomas. So phylloids can infiltrate, but fibroadenomas are very, but it becomes difficult in cases of cellular fibroadenomas of benign phylloids. I depend on hypercellular stromas, prominent leaf-like pattern, and stromal condensation around these samples. There are certain special scenarios in benign phylloids that you should be aware of, because you can see it in benign phylloids as well. You can have areas of minimal invasion or infiltration in the subcutaneous fat. It has been reported, it has been documented, and you can have nodules or these secondary nodules of these benign phylloid tumor around the main tumor. You can have a phylloid completely replaced by an adipose tissue, which is called a lipophylloids. And also you can get osseous metaplasia in the stroma. You can have multinucleated giant cells. They have been studied in various journal articles, and they are mostly associated with a stroma like PASH. So we'll be discussing that later on. But it is to be remembered that necrosis is not a feature of benign phylloids. You can have areas which resemble fibroadenomas coexisting with phylloid tumor, but a diagnosis of phylloid tumor should be favored. And these are the areas where the adequate samplings are not there. You can miss a diagnosis. So you have to properly sample the whole specimen to get the relevant areas. You can have areas like myxoid myofibroblastoma. We will discuss the differentiating features later on. So all these things have to be kept in mind. Now, we come to another category, which is borderline phylloids. It remains in between. It is again a difficult diagnosis, and there is a lot of subjectiveness. The WHO says a mitosis between 5 to 9 per 10 high power field should be put in borderline phylloids. There is a lot of discrepancy as per author of Rosen. He puts it as 2 to 5, but we'll settle down with WHO because that is the criteria being followed globally. So there are a lot of authors which dispute this because they say that if you put it as 5 to 9, the chances of you will be missing the recurrent phylloids very commonly. So there are articles supporting that. But I will stick to mitosis 5 to 9 for borderline phylloids. So in borderline phylloids, you have moderate stromal cellularity that is often heterogeneously distributed. So you have hypercellular areas, you have hypercellular areas more commonly found, and the spindle cell stroma may look like a fibromatosis stroma, a low-grade fibrosarcoma, or a stroma of PASH, which we'll be differentiating later on. And you can have also cartilaginous, osseous, and lipomatous metaplasia. You can have cells which look like lipoblasts in borderline phylloids, but lacking the characteristics of a typical liposarcoma. Focal areas or necrosis may be present as compared to the benign phylloids. There has been a nomogram which has been made by Singapore General Hospital, SGH nomogram it's called. It's a risk assessment tool which predicts the recurrence-free likelihood for phylloids. The website is mentioned here. You can go there, and I just did some scoring and gives out a nomogram score which predicts the reoccurrence-free survival for 1 year, 3 year, 5 year, and 10 years. It is based on scoring of atypia, mitosis, stromal overgrowth, and positivity of the surgical margins. So if you feed all these here, it will give you a result like this, which shows the recurrence-free probability in 1, 3, 5, and 10 years. Now, another problematic area is we distinguish malignant phylloids from primary breast sarcomas and spindle cell metaplastic breast carcinoma. So what do we see in malignant phylloids? First of all, you see a very high mitosis, as suggested by WHO, more than 10 per 10 hyperfield. There is a marked stromal overgrowth. There is a marked atypia and necrosis, and the stroma may contain specific sarcomatous elements such as angiosarcoma. You see an angiosarcoma-like component here. You see a chondrosarcoma-like component with osteoclastic giant cells. You see a rhabdomyosarcoma-like component here. The stroma is very cellular and shows a lot of tumor giant cells. So the moment you have a phylloids which shows all these elements per se, you can label that as a malignant phylloid without any other features. So that has to be kept in mind. So how do you differentiate between these malignant spindle cell breast lesions, which are malignant phylloids tumors, spindle cell metaplastic breast carcinoma, or a breast sarcoma? So if you tell me to distinguish between a spindle cell metaplastic breast carcinoma and malignant phylloids, most of the times we do get these specimens with these kind of morphology. I rely on the PAN3K and P63 because the epithelial component in malignant phylloids is almost always benign. And the cytokeratin labels the spindle cell component, and the P63 also labels that. So ductal carcinoma is usually absent. In many studies, it has been commented that if you get a ductal carcinoma in situ with a sarcoma-like pattern, it should be more towards the diagnosis of spindle cell metaplastic breast carcinoma. Squamous differentiation can be present, but is generally absent in pure sarcomas. Pure sarcomas are very, very rare breast lesions. There are hardly any IHC markers which can sufficiently give out the diagnosis of pure breast sarcomas, but you should have a thorough examination of the samples, and multiple sections has to be taken before you demonstrate the epithelial element to either label it as a malignant phylloids or a metaplastic breast carcinoma. So as I told, P63 and cytokeratins are a big help in distinguishing between the metaplastic carcinomas and malignant phylloids tumor. So another entity which is fibromatosis versus phylloid. So fibromatosis generally of breast, they lack epithelial islands, but as you see here, these long intersecting fascicles, which are of bland spindle cells, they can engulf or entrap these benign looking ducts here. Then it becomes a bit challenging. But what you have to look into is the background stroma is a very thickened collagen which resembles like a keloid. And interestingly, the mitosis are rare, very rare. The CD34 is negative. There is a nuclear localization of beta-catenin. Of course, you see beta-catenin positivity in phylloids also. You rely on CD34 negativity and positivity. So, per se, if you look into the bland morphology, the loosened stroma, the collagenous stroma, you will diagnose a case as a fibromatosis. Myofibroblastomas, another challenge when it becomes very cellular. It can create problems, but there are certain morphology features and IHC features which belong to myofibroblastomas. They are very well circumscribed. It lacks a true capsule and it lacks epithelial component completely. Now, it has a bland, uniform, short to elongated spindle cells which are haphazardly arranged, and they have these collagen bands of hyalinized, brightly eosinophilic collagen which are there among a varying amount of fat also intermixed. Mitosis are usually absent. You can get osseous component, cartilaginous component. Mast cells can be picked up very commonly here. that should point towards a diagnosis of myofibroblastomas. They are mostly accompanied by mast cells. These cells are desmin positive, and very interestingly, they are all RB protein negative. So these are the concluding IHC markers which can help you and achieve the diagnosis. But morphology is very important, and these mast cells in between. Now, radial scars, sclerosing lesions do not generally come into the differentials, but if the sclerosis is too much, then you can have a problem in differentiating between a phylloids and the sclerosing lesions. So, radial scar basically is a low power diagnosis. Generally, it looks like a low power stellate configuration. You can see here these two, and there is a center sclerotic zone which is composed of fibrosis and elastosis, and with ducts and lobules. These ducts and lobules can show various ductal hyperplasias. It can even show florid hyperplasias with necrosis. You can have varying degrees of scleric adenosis, apocrine metaplasia, and cystic change. So it's a low power diagnosis. You can look into it and see the stellate pattern. If you come to sclerosing adenosis, again at low power, it is a lobular structure. The lobular structure is maintained. There is an increase in glandular as well as stromal component, and it distorts and compresses the gland. So it maintains a very lobular structure, which you should be able to make out in low power. PASH can coexist with phylloids. It is usually found in borderline phylloids. What is PASH? PASH is basically a pseudo-angiomatous stromal hyperplasia. It's basically, these are the spaces which are there, which are separated by thick collagen. And these spaces at times can be lined by these cells, which are actually myofibroblasts. These spaces are usually empty, but can have RBCs in between. And you can see from here, this is a PASH and a high power view of PASH here. So there is no mitosis, there is no necrosis, no atypia. Rarely, as I told you earlier, you can have multinucleate giant cells accompanying PASH. So there is a variant of PASH which is called fascicular PASH. It's a very cellular variant where the myofibroblast aggregates into fascicles, where there is a reduced or absent clustering. It resembles a myofibroblastoma, but myofibroblastoma are RB protein negative, as we told them, and they are almost always SMA positive and strong PR positive. Of course, their CD34 positivity is also seen. So, a PASH can be a tricky thing. It can coexist in phylloids tumor, but these are the morphological features to look into, and IHC might be able to help. So, immunohistochemistry of phylloids, it has to be touched. So, it has an epithelial component and stromal component. The epithelial component, it is positive for various cytokeratins. The ER expression, ER-PR positivity is there. Hertinio is positive in about 60% of cases. The ER expression correlates with a benign phylloids towards the higher grade phylloids. It's more positive in benign phylloids as per studies. It's around 67%. And in higher grade phylloids, around 40%, 43 to 47% in low to high grade phylloid tumors. GCDFP15, another marker for breast, is always positive in these epithelial components. Stromal components are almost always positive of vimentin. CD34 positivity is also known, but it reduces with the grade of the tumor. It becomes lesser and lesser as it becomes malignant. PR is almost positive. ER beta is positive, and androgen receptor is almost always negative. It is lost androgen receptors, which is found in less than 5% of cases. Hertinio is negative. There have been various studies which have been done on c-KIT, CD117. It has been shown that higher intensity was found in higher grade malignant phylloids and also correlated with a higher recurrence rate. But subsequently, there was no c-KIT or PDGFRA gene mutations which were found as per PCR. So they concluded that c-KIT does not appear to be a suitable target for treatment of phylloids tumor. So if you look into P53, Ki67, we have already touched upon that. The P53 and Ki67 increases with the worsening grade. One point to remember is that you should look into the P53 positivity around the epithelial element in the subepithelial where the condensation of stroma is there. It increases there first. So P53 and Ki67 increases with worsening grades. And the epithelial and phylloids also plays games. So you can have varying degrees of epithelial hyperplasias, which is maximally found in borderline PTs, about 83% of cases. All benign phylloid tumor can have about 74% of can have epithelial hyperplasia of varying grades. And of course, lower grade or higher grade malignant PTs have a lesser epithelial hyperplasia. Squamous metaplasia, apocrine metaplasia, all are known. This is an apocrine metaplasia. So these are all known in phylloid tumor. But it has to be very, very carefully reported. If you find a focus of intraductal carcinoma, DCIS, rather keep a higher threshold to give out a diagnosis of DCIS and phylloid tumor as per various journal articles. You should look into, in the lower grades, you generally don't, or lower in the higher grades, you don't find DCIS. You should more support a diagnosis of metaplastic breast carcinoma if you find foci of DCIS as per journal articles. So what is the summary and the practical recommendations which we carry home now is that the grading of phylloid tumor should aim to achieve accuracy between the malignant and the benign counterparts. There is the definitive distinction between cellular fibroadenomas and benign fibroid tumors may not be very crucial because they have similar reported recurrence rate. As per journal articles, it's about 15 to 20%, fibroadenomas about 12 to 15%. And the presence of malignant heterologous component, as I told you earlier, component of angiosarcoma, osteonic sarcoma, liposarcoma, it places the tumor into malignant category regardless of other histological features, which is very important. From a diagnostic and management perspective, it is important to accurately recognize the malignant phylloid tumor, which should be surgically eradicated, effectively treated at diagnosis, as these tumors lead to high risk of metastasis and death. Thank you very much. I am open for discussion if there are any questions.
Thank you so much, sir, for such a wonderful explanation. I know pathology is always all about this. It's very complex, but it's our right to convey the right message to the surgeon so that they can plan the surgery accordingly. And it is always best for the pathologist to convey the report as much as possible on the core biopsy, if possible. And if not, then excision biopsy or the resected specimen always gives us the right diagnosis and appropriate diagnosis.
Absolutely.
Is there anybody who want to ask somebody? Ask any question to Rajan, sir?
We'll take up the questions at the end of the session, Raji.
Okay.
So, yeah.
Okay.
Let's start with our next talk by Dr. Smriti Hari, ma'am. Over to you, ma'am. Please start with your presentation.
Right. I will just be sharing. Okay. You have to stop sharing, then
Yes, sir.
Wait.
I'm just stop share. Yeah, sure.
Right. Yes. I hope my screen is visible.
Yes, it is.
First of all, I want to thank my stars that I'm not in Dr. Rajan's shoes.
I have to only say the degree of suspicion for malignancy in my report. I don't have to worry about the very tough task of giving specific diagnosis. So let's come to the topic. And the outline I have made is about the questions that probably a surgeon would like to ask a radiologist about any phyllodes tumors. Whether you can really distinguish phyllodes from fibroadenoma on imaging features, how often can a radiologist suggest correct diagnosis of phyllodes tumor before biopsy based on imaging features? What happens to equivocal fibroepithelial lesions on biopsy, which is a large share of the biopsy reports that we get? Do we need to excise all? Can imaging help in telling us which one we can follow up and which need a diagnostic excision? Of course, whether we can distinguish malignant phyllodes from benign, and what are the usual imaging differential diagnoses of phyllodes tumors. So, phyllodes tumors on mammography, it is a mostly ovoid, high density mass, and you can see that it is well circumscribed and it has slightly lobulated margins, which become more and more prominent as you see the large phyllodes. And sometimes you can see the differing densities within the large tumor. Yeah.
Ma'am, your PPT is not moving in. Can you please make it full screen?
It is full screen. Ovoid, round, and well circumscribed margins. They get more and more lobulated as the tumors grow in size. And very often, you see a lucent halo, which is because of the compression of surrounding fat. And we kind of find that to be reassuring because that means there is no infiltration in the surrounding tissue. On ultrasound, again, you have circumscribed margins, like in this case, or you may have slightly non-circumscribed margins. What is characteristic is that the internal architecture is heterogeneous, as against fibroadenomas, which tend to be more homogeneous. The heterogeneity comes in the form of differing echo pattern, as well as cystic areas, which could be rounded in the periphery, like in this case, or you may have very thin slit-like cystic areas. In this 13-year-old girl, we could give a pre-biopsy diagnosis of phyllodes because of these cystic spaces, which are very slit-like in this image. Now, MRI is not commonly performed to diagnose phyllodes, because once you will see the tumor on mammography and the ultrasound, you would straight away go for an ultrasound-guided biopsy. But the features are also, again, not very specific. The major criteria for diagnosing phyllodes, even on MRI, is the heterogeneity. As you can see in this contrast-enhanced image, where you can see contrast in the vessels. So this is contrast-enhanced. And what you're seeing is that some parts which were solid are enhancing, and the parts which are cystic are not enhancing. And it's a very mixed kind of signal intensity. And the cystic lesions are sometimes bright on T1 if they consist of hemorrhage. If they are necrosis, they will be dark on T1 and bright on T2. And this is the kinetic curve, which tells us how the contrast is coming into the lesion and coming out of the lesion. So you see that there is a rapid intake, and then it continues to be in the lesion. It's not washing out. So washout is a marker of malignancy because of the leaky capillaries of the neoangiogenesis. So this is hallmark of a more benign lesion. So how often is a radiologist able to give a diagnosis on imaging of phyllodes tumor? I'm afraid not very often. It is only 25% of time that, based on the imaging features, for example, this case, you can suggest a diagnosis of phyllodes, where we are seeing these cleft-like, slit-like cystic spaces. More than the imaging features, the radiologist also bases a suggestion of phylloids on a large size of the tumor and history of rapid growth. So talking to the patient is again important for the radiologist also, and you can then probably suggest the correct diagnosis. So phylloids versus fibroadenoma. Phylloids comes at a later age, has a larger size, is more lobulated, more heterogeneous, and there are internal cystic spaces which are slit-like or rounded. Now I will say a few examples where we'll try to see if imaging is able to suggest the correct diagnosis. This is a 35-year-old lady with a lump in the left breast for 2 years, and she says that it has progressed rather slowly in size. And we can see a circumscribed high-density mass on the MLO view as well as the CC view, which looks circumscribed. And in the mammography as well as in the ultrasound, it is the margin which is the most important feature, which guides us towards benign nature or the malignant nature of a lesion. So again, on a ultrasound, I see it as an oval and very well circumscribed lesion and rather homogeneous. I'm not seeing any cystic spaces. But to me, I would think that this is a fibroadenoma. But when the biopsy was done, it came as a benign fibroepithelial lesion favoring a phylloids tumor, and an excision was advised for confirmation. And when the surgical excision happened, the multiple sections which were examined showed actually a fibroadenoma. So we are as confused as the pathologist, because there is so much of overlap between fibroadenoma and small phylloids tumors, both on imaging as well as on pathology. So there was no evidence of any phylloid-like features when it was excised. Another case, fibroadenoma or phylloids tumor. So you can see a lobulation here. It is again very circumscribed and similar looking to the previous case. And again, I would think it is a fibroadenoma. But this time, the biopsy again said that there is preponderance of cellular stroma, features are suggestive of phylloids tumor, and when surgical excision happened, the final report was benign phylloids tumor with minimal mitosis. So these two cases show us that when the tumor is small, it is very difficult to label it as fibroadenoma or phylloids. So what we in radiology would do is just suffice to give our BIRADS assessment, which will say which will convey the suspicion of malignancy in this mass, and that appropriately should be 4A in these cases, because they have a low suspicion of malignancy, which is to the tune of 2 to 10%. Now, coming to the next question, whether we can differentiate between benign and malignant tumors. So, here is a case which looks very circumscribed, very high density, and it looked rather heterogeneous on the ultrasound. So I would consider a phylloids in the differential. And this tumor at the time we saw in mammography was about 5 centimeters. And by the time she underwent an excision 2 months later, the tumor had grown to almost 10 centimeters, and the final diagnosis was indeed malignant phylloids tumor. So the pointer towards malignancy is not the imaging feature, but the rapid growth in this lady. A 45-year-old lady with slowly progressive lump for 3 years, and you can see that they in fact look like multiple lumps to me, and they are lobulated, circumscribed. Similar picture on the ultrasound, and if I may say so, probably there is some cystic areas, the kinds which we expect in phylloids, and so we gave a possible diagnosis of phylloids in this patient, and very difficult to say about malignancy. We would rather give it a BIRADS 4A. And in the biopsy, it came as fibroepithelial lesion with a possibility of both fibroadenoma or benign phyllodes, and excision was advised. So the surgical excision actually showed that there were all multiple hyalinized fibroadenomas and few phyllodes-like features. So this again shows us how closely fibroadenomas and phylloids tumors, benign phylloids, are related. And the only clue in this patient towards the benign nature may be that the history was long and the progression of this lesion had been rather slow. Sorry. So now coming to another patient who of a 42-year-old and who was operated twice in 2 years outside the institute. And first time the biopsy had shown mixed fibroadenoma, second time a phyllodes tumor. And again we see tumors which look like two different tumors abutting close to each other. And this is how they looked on the ultrasound with cystic areas and heterogeneity. So, the biopsy said that this is a single cell tumor with disc mitosis, and it was suggestive of a malignant phylloids tumor, which was confirmed on a radical mastectomy with underlying muscle specimen, because again there was such a rapid growth in the time between the imaging and the excision, and it was indeed a malignant phylloids tumor. A lady with left breast lump in the retroareolar region for 1 year. Again, we are seeing a dense mass, and which has a circumscribed margin, and it seems to be infiltrating the areola, and it is close to the skin, and there is vascularity within. The biopsy showed benign phylloids, and the surgical excision upgraded it to borderline phyllodes tumor with a mitotic activity of 7 to 8 per 10 high power field. 38-year-old lady with lump in the right breast for 1 year. Again, we are seeing a similar mass, very circumscribed, with some heterogeneity, some lobulation on the ultrasound. The biopsy said benign fibroepithelial lesion, and the excision was advised. Surgical excision showed it to be a benign phyllodes tumor. So this brings me to a question, and which was elegantly answered in this very interesting article, which said that do we have something else in our imaging modalities which can help us to differentiate the equivocal fibroepithelial lesions into possible fibroadenomas which can be followed up, and the phyllodes which would of course require excision. So they added shear wave elastography and color Doppler ultrasound to a B-mode ultrasound, and they hypothesized that this addition may preoperatively distinguish fibroadenomas from the equivocal fibroepithelial lesions on biopsy, and then we could possibly reduce the number of unnecessary diagnostic excision procedures. Why this hypothesis? Because the biopsies are sampling only a very, very tiny part of the tumor, and therefore there is a sampling error. And whereas when you see the stiffness, that is what the elastography measures, you are seeing it in the entire lesion, and the color Doppler is also giving us a holistic view of the vascularity of the whole lesion. So this could supplement the shortcomings of biopsy. So they had good results. They thought that when it is a phylloids tumor, the vessels are more, and it shows little hard areas, not as much as in cancers, but you see this green area in this machine. The blue is saying soft, is showing soft areas, whereas the green is a little harder. So in the periphery you see these harder areas, and a fibroadenoma on the other hand showed all blue. So it is soft and it hardly has any vascularity. So if we add these two features to our grayscale ultrasound, maybe we can better predict that it is a phylloids tumor. Important role of imaging is in large, giant phylloids tumors, which are more than 10 centimeters. And the imaging becomes very challenging because mammography is not tolerated, not possible when there's such a huge tumor. Ultrasound will not give us a holistic view. We will only be seeing a very small part of the tumor at a time. So at these times, we need to do cross-sectional imaging, which could be CT or MRI. Most of the times, CT suffices. And the reason we do CT is shown in this lady. She was a 23-year-old girl and she was having this mass since she was 17, and this was operated 6 times, believe it or not. And every time this lump would recur. And when she came to the institute, we first did a CT to see the extent of the mass, whether it is involving the underlying muscles, the skin, any metastases which were there. So the diagnosis was malignant phylloids tumor based on the biopsy with recurrence, and she had to undergo multiple operations. The first one being radical excision of the tumor with part of the underlying sternum and 4 ribs because it was stuck there, and a LD flap cover was done. Unfortunately, after 3 days, the LD flap started becoming gray and the mesh got exposed after its necrosis. So then the second operation was done where she had an ipsilateral vertical rectus abdominis flap. And then the third operation to cover the raw area of the back and front wound. So multiple surgeries. So phylloids tumor, I think it's dreaded mainly because it is so disfiguring. Even though this was malignant, but even patients for benign phylloids need such big surgeries which are very disfiguring. And at that time, cross-sectional imaging is very useful. Another patient where you can see the size of the tumor, it is giant, it is huge malignant phylloids tumor, and it is only with, in fact, MRI will not be possible because this lady will not be able to lie prone. So CT becomes the best and the fastest modality at that time, where we are happy when we see that it is away from the underlying chest wall, though it seems to be compressing the pectoralis muscle. So this lady was operated with a mastectomy and shaving of the pectoralis muscle, but unfortunately within 3 months there was a recurrence and we had a parasternal mass, and which was, then she was put on chemotherapy, and after chemotherapy you see that still the mass is growing even though there is necrosis within the mass, which is seen as cystic areas. This brings us to the topic of follow-up imaging. Phylloids tumor, as it is increasing in the grade, there are the dreaded recurrence is there. So what is being followed at the institute is that 6 monthly clinical examination is done for the first 2 years, and then yearly examination. Imaging is only suggested if any abnormality is detected on clinical examination, and then we could investigate it with either ultrasound or CT or MRI, because most of these patients have undergone mastectomy. Lastly, what are the differential diagnoses that a radiologist considers when we are faced with large tumors? This is the list: a giant fibroadenoma, a lactation adenoma, a hamartoma, a juvenile papillomatosis, and sarcoma, apart from the phylloids tumors. These are the differential diagnoses. A few examples from my experience. This was a 22-year-old with sudden breast enlargement of the left breast during lactation. And you can see that the left breast is markedly enlarged, and there is a tumor inside which is actually looking a lot like the rest of the breast parenchyma. So we were very foxed by this, and we thought that it is either a lactational adenoma or a phylloids tumor, and did an ultrasound guided biopsy which showed us that the benign breast parenchyma with adenosis and lactation change. So then final diagnosis we made was that it was a hamartoma in the woman's breast, which she did not feel earlier, but then it underwent lactational change and became very apparent during lactation. This is another case in a 14-year-old of breast enlargement. This is an old case. So the enlargement was such that we had to use a curvilinear probe to show the involved area. And you can see a lot of cystic areas and a heterogeneous appearance. And we made a diagnosis of phylloids tumor again in this patient. But on biopsy, it turned out to be a juvenile papillomatosis. So juvenile papillomatosis, when it is large, can look like a phylloids, because again it will give us a very heterogeneous appearance. This is a girl who was 12-year-old with an enlarged left breast, and it was painful. There was no fever. So there is this, again, we made a diagnosis of phylloids tumor looking at the small cystic areas, very thin cleft-like, but this turned out to be a juvenile fibroadenoma. To conclude, I would say it is difficult to give imaging diagnosis of phylloids tumors, especially when they are small, because then on imaging they look very much like fibroadenomas. Again, imaging features overlap between benign and malignant phylloids tumors. Cross-sectional imaging is required for surgical planning of big phylloids tumors and for recurrent phylloids tumors. Imaging surveillance should be done for 2 years after resecting borderline and malignant phylloids tumors. Thank you.
That was an excellent, series of cases, and we are very. That was really enlightening, because you are the one who has so much of experience with all these, presentations and final radiological and pathological diagnosis. So thank you so very much, Dr. Smriti. I just wanted to truly, see pathological.
Thank you so much.
Pathological. They are critical factors in decision of the treatment, and when it comes to a surgeon, I know I can share those experiences where you're really stuck. The patient comes, young girl coming 23, 24. This case you shared, definitely it was something very radical that she needed, because she already had a malignant phyllodes, and I'm sure the surgeon
this is not uncommon. We get to see large phylloids very frequently. And yeah.
So I think I would share a bit of experiences with you later in few cases, but the thing is, possibly the kind of presentations we have at corporates or private is a little different from what we have at the government institution.
Sure.
People are definitely facing more challenges, larger tumors with maybe malignant potential, spread, recurrences. Definitely. So phyllodes otherwise is not just a rare entity, it is a challenge for a surgeon as well. And we are handicapped without a good pathologist, without a good radiologist. So I would really thank all the people on board who are working and giving us that diagnosis, so that we can, go along with the patient's wishes. I think we'll take a few questions. Prachi, can you just have a look at the questions and we can take up those? Dr.
Rajan sir has already answered the questions in the chat box. There were only 2 questions.
There was a question regarding Paddington criteria. I don't know the current trend is not towards FNACs of breast.
Exactly.
Idly telling you the Paddington criteria, how true it is nowadays is very difficult to say, because we generally resort to true-cut biopsies for all breast lesions, and because it helps in two ways, is to morphologically assess the tumor and to do an IHCs on the tumors for prognostic markers, and the treatment can be started. So I don't know whether that Paddington criteria still should exist.
So there is only one question that was asked by Nirja ma'am itself to Dr. Smriti ma'am. What's your experience with color Doppler, ma'am?
Yes, color Doppler can help in equivocal lesions because we find the phyllodes to be more vascular, but then at the same time the fibroadenomas which are cellular and in younger women can also be vascular, but more vascularity is there in malignant lesions, so it can be a tiebreaker sometimes. Again, there is an overlap between the sclerotic fibroadenomas will not show much flow, but the cellular ones can. So still there is an overlap.
If you allow me, can I put one question to Dr. Nirja? I've been waiting to put this question to Dr. Nirja.
Yes, sir.
How important is it for the clinician to know whether this is a fibroadenoma or a benign phylloid? Leave aside malignant. Is it really important? If you look into the statistics, even if you leave a positive margin, the recurrence rate doesn't change. I've gone through many journal articles. So why do we really stress upon giving a diagnosis, whether it is a fibroadenoma or phylloid, on a limited tissue or a limited cytology sample?
So to answer this, I'll just go back to the entire discussions we had. So when it comes to excision, the belief of the surgeons is very, very varied. It varies from about no margin to about 5 centimeter. The practice is definitely evolving. People are learning, but because they have had disastrous consequences, maybe, or because they had very bad experiences with the recurrences, they still tend to take wider margins, especially in centers which are high volume, or the centers where they're not sure about how much margin they would be taking. The two main factors that we don't want a second surgery, we don't want a recurrence. So something that supports both of it should be important. So for when a patient comes to me, and if one thing I make sure that she doesn't have a history of recurrence, because sometimes if you don't ask, they will not come out of it. If that recurrence is there, definitely my planning of the treatment changes entirely. I'm looking at that patient as a recurrent phyllodes, number one. Number two, what the patient wants. If the patient really, really wants conservation, now that is where I need to know whether it's a fibroadenoma or a benign tumor or a borderline or something like malignant. I understand that it is very difficult on the part of pathologists to differentiate between a borderline and a malignant one. So if they report borderline, I usually take it as either borderline or malignant. That means I have to have wider margins. But if they report it as benign fibroepithelial lesion, I understand either it is a fibroadenoma or it is a benign phyllodes. So I'm a little settled there. So now if the patient comes with she wants conservation, she doesn't want her breast to be out, and usually they are large. I have never seen small phyllodes. I have always seen more than 5 centimeter, 10 centimeter, 12. We'll show you a few cases also. So in that situation, if my pathologist is telling me it's a benign thing, and I definitely 100% rely on my pathologist. So that is what I'm trying to say. So without you people, we are handicapped. So in that scenario, I would definitely intend to take a centimeter margin. But if the margin is close near the skin, and I know it is a benign phyllodes, I know it is a benign thing, I would not shave off that skin if the patient wants the conservation. Now, your question, how important it is to understand the fibrinoma and benign. So, thing is, till date, there was I have operated around 7 to 8 cases, large payloads, almost the entire breast. There was only one case where the pathological diagnosis shifted from benign to borderline. So that was where I was a little, worried. But in that case, I had already taken the skin because we could not do. We could not just, do away without taking it. So I had to replace it with a skin-based flap. Otherwise, all of them, they corroborated very well with the preoperative diagnosis. So when in these situations, the pathologist is like a basement layer of brick stone without which I cannot operate. I cannot decide the treatment because I don't want to take the patient for a second surgery on the table. That is for sure. So it's very, very important to understand what kind of tumor it is. So we are going to show 2 or 3 cases. Prachi, can we have the cases here, please? These are 2 cases are my cases from Dharamshala, and one I think some other surgeon had operated. Can we have that? Okay, I'll have to share the screen. Yes.
Ma'am, you want me to share? I can share it.
No. That's not the PPT. Just. Can you see the screen, please?
Yes, please.
Yes.
So this is the case that presented recently. She is 36 and she has a breast lump, entire left breast. And she wants a conservation. She recently had a pregnancy also, which she got aborted. And the lump was constantly growing as we expect, because during pregnancy, all these lumps grow like the banyan tree roots and all. So this patient had an ultrasound. Can you share the ultrasound report of this patient, Harmeet? Harmeet is the consultant radiologist with us in Dharamshala Narayana Hospital. Harmeet, hello.
Ma'am, are you there? Harmeet, ma'am?
Okay. So I'll just brief. This patient underwent ultrasound, and she had a left side big tumor, and right side also she had small tumor, which I planned to remove at the same time. But since she wanted conservation, this tumor was out with an incision in the lateral mammary wall, the lateral mammary fold. And I sent this patient did not want a biopsy for sure. During her she wanted something that could be covered under anesthesia. So I did a frozen true cut for her, sent it to Prachi, and the pathology department reported it as mostly benign and nothing malignant. So I was pretty sure that there is something which is going to be on a favorable side. So I planned a wide excision for this patient, and this was a lateral mammary fold through which I removed the entire tumor. Definitely, it was intended to have all the margins, so hardly any breast tissue was left. That was in the inferior 6 o'clock position. But I planned almost a total mastectomy for her, and with that, there were two flaps which were taken. One was a lateral flap, and one was a LD also, because this was mostly a benign thing. So the LD, I need not keep it for a second surgery, an implant with or without LD. So I took LD as well, and this was something which looked on the ICG. And this is the patient on the first post-op day. She just came, this was last Saturday morning, and today morning she came to me and she was looking absolutely fine. The drain is pouring about 100 ml, so I've decided to remove it maybe next week. But the patient is absolutely fine, very, very happy. And as you can see, very, very identical and symmetrical breasts. So to us, such kind of challenging cases come, and without the support of the pathologist, without the reporting which is close to the final diagnosis, it's very, very difficult to take a decision, because you want to preserve the LD, you want to give a good shape, you want to preserve the breast. So all these challenges I face, at least with my patients, they come to me and they demand, I want to keep my breast. That is one. That is where the differentiation. And I think we can have the second case also, Prachi. Hello.
Ma'am, can you hear me?
The second case. So this 65-year-old, 65-year-old female, and she had about 6 centimeter lump, and the mammogram that showed the posterior margin obscure. I was not happy with that mammogram. I could not show you that film because the entire thing goes in the TPA. So that mammogram was something I was very, very unsure of the posterior margin, and I asked her to undergo ultrasound guided biopsy because she had some FNAC from outside with said atypical cells. Looking at the mammogram, I was a bit suspicious for this to be malignant. But then she underwent an MRI also. So do we have that slide? You can share the screen. I'll stop sharing mine.
Yes, ma'am. Is the screen visible?
Yes. So this is the MRI of this patient, and you can see on the right side, in the right breast, there's a very large lobulated, well circumscribed mass, and this mass is showing mildly lobulated and irregular outlines on the medial side. However, the rest of the breast does not really show any architectural distortion. So, So on the next slide, this is the diffusion images. We see that there's actually, medially we see areas of mild diffusion restriction. However, the diffusion restriction is not very severe for us to confidently call it a Byrad's file. Can I have the next slide? So these are the post-contrast images. Here we see a very well-enhancing mass, which with actually areas of cystic changes within. There are non-enhancing areas. Again, well-enhancing mass with cystic areas and microlobulations. And the kinetic curve was a type 2 kinetic curve, which for us means which is indeterminate, borderline suspicion for malignancy. So we on radiology MRI report, we gave this as a Byrad's 4B lesion with a suspicion for malignancy.
So further, this patient underwent a biopsy post-imaging. And so these are the core biopsies which we have received at our department. So in this focus, you can see only 4 cores, 1, 2, 3, 4. So overall, if you see that there is a lack of epithelial component as compared to the stromal component. This is the stroma and this is an epithelial component. So if I put the stromal component into high power, what we have observed is this. So these are the cells which are closely placed, and there is a stromal overgrowth as compared to the epithelial element, as it has already been described by Dr. Rajan sir very well. I would not like to go into much detail. I would like to just conclude by saying that though it was Byrad's 4 radiologically, but pathologically the definitive diagnosis attained was of benign phyllodes. This patient underwent further resection, and these are the slides from the resected specimen. This is the leaf-like contour of the benign phyllodes, and this is the high-power stroma, which is showing very mild atypia, lack of mitotic activity, and no foci of necrosis was seen. So definitive diagnosis of benign phyllodes was rendered in this case. So many a time there is a discrepancy between radiological and pathological diagnosis, especially in this case of a notorious tumor phyllodes. So it is our responsibility to convey the right diagnosis to the surgeon on core biopsy as much as possible. I've already mentioned earlier also, though the definitive diagnosis is always attained on resection or excision biopsy. So this was a discrepancy here that though it was a BIRAT score, but it turned out to be benign.
Can I just say something, Harmeet? I don't think it was a discrepancy because BIRATS 4 doesn't mean that we are calling it malignant. BIRATS 4 just means that we are giving it, we have suspicion of malignancy, and when you give it a 4A, that is under 10. So when you're calling lesions 4A, 90% of the time they will turn out benign. But any phyllodes tumor, this lesion, you cannot call it anything but BIRATS 4. So 4A was the correct nomenclature to use, and the expected diagnosis indeed is benign in 90% of this category. So that was the correct assessment.
So 4A is a little suspicion, but yes, this is something that you don't want the patient sending away for a follow-up. So you have to, look.
Yes. If somebody would have asked for just follow-up in this patient, I would call that wrong. BIRATS 3 here would be wrong. It has to be a BIRATS 4, but a lower BIRATS 4, not a 4C, but a 4A is appropriate.
Yes.
I would also like to put in a point here. Sorry to interrupt. So this stromal overgrowth, when you look into a true-cut biopsies, if you go through the journal articles, in case of complete specimen excision, it is 4x. You look into the low power. But when you look into the true-cut biopsies and you give stromal overgrowth, you have to give it in a criteria of 10x, not at 4x. So you can search journal articles.
Yes.
They say stromal overgrowth has to be assessed at 10x and not at 4x in true-cut biopsy.
Yes. Absolutely right, sir.
Yeah. So Prachi, you people are doing at 10x, right, or 4x?
No, ma'am. This view is a scanner view where you could see the four cores, and this is a 10x view.
10x.
So this is a stromal overgrowth. Yeah.
Yes, sir.
What was
So
the
this is
mitotic
the-
count here?
Sir, mitotic count was hardly 0 to 1. There was no mitosis in this. There was no foci of necrosis. It was completely bland tumor. It's showing the... Sir, you can see here, one second, sir, I'll show you. Yeah, this is a resected specimen, sir. You can see here this phalloidal pattern.
Yeah.
And this is the high power view, 40x, where you can see the bland, and there is not even much nuclear overlapping. I should say there was a mild cellularity if you go as per the criteria of cellularity.
So this image is from the tumor resection or this from the core needle biopsy?
Sir, this is resected tumor, and this one is the core needle biopsy, this power.
So when we talk about core needle biopsy, as I told you that if the mitoses are not enough, not more than 3,
Yes.
then you revert to at least 3 criteria, parameters.
Yes,
as
sir.
per journal articles, there are a lot of studies being done.
Yes, sir.
So in this sense that I can see one of them, that is the stromal overgrowth. The rest...
Actually, there were many more cores here. What I could focus is only these 4 cores. There were some 6 to 7 cores in this biopsy.
What I'm saying is, could it be borderline?
Sir, it was not. On resected specimen, it was not, sir.
Not? Okay.
No.
Right. Fine.
Turned out to be benign fillers. Yeah.
Yes.
Benign.
Fine.
Okay. So it's definitely not a cellular fibroid.
Yes, definitely, sir.
Yeah. Right.
So is that all, Prachi? We're done?
Yeah, ma'am, there is one more case.
Yes. Please
If you
carry on.
want- Yeah.
Yeah.
So there was a 42-year-old female. She presented with breast lump. So these are the MRI imaging. It will be detailedly explained by Dr. Harmeet, ma'am. Ma'am, please.
Yes. So again, we'll start with this axial stirred image of the breast. Here we see the very large mass, almost 10 centimeters, that is occupying almost the entire right breast. So this mass is very different from the previous image because this we can see a lot of solid cystic areas within this. If I could just have the next slide, please. Okay, so in this, this is the diffusion weighted images. We can see the ADC value was actually quite low in areas, which again pointed more towards malignancy. Posteriorly, you can see the margin is extending till the pectoralis major muscle. Though we didn't really see any infiltration on MRI into the muscle, but we could see that it is closely abutting the superficial fibers. Again, so this is the image of the post-contrast study. Very hypervascular mass, as you can see, large internal mammary artery on the right side supplying this lesion. So this mass was given by us as BIRADS 5, which means highly suspicious for malignancy.
So actually, I don't have the needle core biopsy of this patient. I have only the resected specimen findings. So it was all correlated with the radiological finding, and it turned out to be malignant phyllodes. You can see so many mitotic activity. This is the high power field, that is the 40x, in which we actually count the mitotic activity. So you can see so many here in this field, 1, 2, 3. These are the atypical mitosis. You can see the multipolar thing. I know only a pathologist I can make out this. It's difficult for other branches to make out, but just for the for the detailed histological view, I would like to highlight that there are many mitotic activities in this. And you can see the cells are so much atypical as compared to the last slide. If you remember, the cells were very much bland, and here the cells are showing almost moderate to marked pleomorphism. And you can see the cells are even overlapping each other. So there is a marked increase in the cellularity as well. So there were many factors which were favoring the diagnosis of malignant phyllodes in this case. And this is just a picture I wanted to highlight that this is the resected margin, and it was very close, hardly 2 mm from the main tumor. So all the peripheral margins were like this in this tumor. So this was a resected margin, and it was around just 2 mm from the main tumor, and it turned out to be malignant phyllodes.
So she must have had a re-resection, 2 millimeter.
Pardon, ma'am?
2 millimeter margin needs a re-resection or a mastectomy.
Ma'am, actually, this case was recently operated. The lady has not turned out yet.
Come for this is not my case. So.
Yeah, this is not your case.
Right. So I think we had a very nice and a long session, but because the radiologists and the pathologists are the foundation stone, and we really can't do anything without them. Our decisions purely depend on your diagnosis, your conclusions, and it helps us a lot in deciding the treatment for the patient. So that is why this session was very important to me, and I'm sure the viewers also have enjoyed a lot. Thank you so much. Are we left with any questions? I think we're done.
Dr. Reja, I think there is a question for you.
Do you recommend radiotherapy in malignant phyllodes? Yes, I do. Unless and until it's less than 5 centimeter, this is what MD Anderson says. Any tumor, malignant tumor, more than 5 centimeter, any malignant tumor in an area where infection is not possible should undergo a radiation therapy. That is what the MD Anderson guidelines and the NCCN guidelines suggest, and we follow that. Yes, I do. So I would recommend RT in large phyllodes more than 5 centimeter, or in an area where the resection is difficult, the chest wall, all those areas where it is difficult, yes, this RT would be recommended. Anything else that we have? I think we are done. Wonderful presentations, comments from the viewers, from the attendees. Thank you so very much. Thank you, Dr. Rajan. We enjoyed the discussion so much. And Dr. Smriti, thank you so much for your time, all of you.
Thank you, Dr. Reja, for bringing us together. Thank you very much.
Thank you.
Thank you.
Thank you.
Good night.
Thank you, both of you.